look like we're still creeping up, but why don't we go ahead and get started? Good evening. My name is Lee Osterman, and I'm the moderator tonight. This is the AO Trauma Hand North America online series, and this is the 9th webinar of the Advanced Wrist Summit. Tonight's talk deals with the role that wrist arthroscopy plays in the treatment of wrist conditions. We have, aside from yours truly on the faculty, we have Will Geissler, professor from the University of Mississippi, Tom Hunt, who's the chairman of Baylor Orthopedics, go Baylor, as he has said, and lastly, Rob Wysocki, associate professor at Rush. Our conflicts are listed here, but none are pertinent to this talk, and all have been resolved before we were allowed to speak. Zoom etiquette really asks you to keep your microphones muted and your videos turned off. There is a Q&A if those of you who all use Zoom can ask questions in there. We will monitor that, and one of the faculty will try to answer your questions as they come up. Our learning objectives are really here, and the bottom line is we want to show the increasing role that wrist arthroscopy is playing in treating conditions of the wrist. So we've got some very common ones, which all of us are using, and some uncommon ones, which can generate some controversy. So we're going to have Tom Hunt go first, followed by Will Geissler, followed by Rob, followed by yours truly, and then cases, etc. Well, if we explore the boundaries of wrist arthroscopy, it's really about 30 plus years ago at the ASSH meeting that the first 2 clinical papers on wrist arthroscopy were there. Since then, wrist arthroscopy is the fastest growing site of arthroscopy in the United States. There's certainly more knees, shoulders done, but our closest rival is the hip. Well, what have these 3 decades of wrist arthroscopy done? Well, they've enhanced our dimensions of surgical anatomy. They've really opened up some of the questions that could only be answered by looking at wrists that were live. They've allowed us to make more accurate diagnoses, and we now have therapeutic options for many conditions. Well, improve wrist anatomy. Looking at this classic 3-4 portal, we see the radial extrinsic ligaments, the radioscaphocapitate, long radiolunate ligament. We see the vascular leash. We see the lunate above, the radial facet below. We're looking now at the short radiolunate ligament. As we swing over, the probe is in from an ulnar portal. We see a small linear tear in this triangular fibrocartilage, which we see here. We can look back at the whole edge of the triangular fibrocartilage as we move essentially westward on the wrist. We can see the prestyloid recess at the tip of the probe, the edge of the TFC. We can begin to see the LT ligament. Now, the best view of the LT ligament is coming in the ulnar portal, and here we're looking directly at the cleft, which is the LT ligament, the ulnar extrinsic ligaments below, and we can easily, in most wrists, look directly in the piezoterquetral joint, which is one of the more common sites of osteoarthritis as we age. As we come back, we can look back across the wrist at the surface of the radius for fracture reduction. We can see the scapholunate ligament, and as we go dorsally, we can see where a ganglion might arise. It is important, I always argue, that looking in the midcarpal joint is as important. When you scope a knee, you look in the patellofemoral joint. Well, when you scope a wrist, you should look in both the radiocarpal and midcarpal joints. The midcarpal joint gives us an excellent view. We can see the interfaces of the scaphoid, lunate, and terquetrum without ligament covering them. We can go all the way up and look in the triscaphe joint, as we're seeing here. We can look ulnarly at the type of lunate we have. This happens to be a type 2 lunate, capitate on your left. We can look at the small fat pad. You see the triscaphe again on the left screen, and we can look up at the hamate and see if there are any shear lesions or arthritis on the hamate. And so wrist arthroscopy has both a diagnostic and therapeutic use. It helps us with some of the riddles we have on the ulnar side of the wrist. Diagnostic indications maybe to help us establish a diagnosis, confirm a suspected clinical diagnosis, and define the extent of the damage in the wrist and stage surgical treatment. We then have a number of therapeutic options which are growing daily and which we're going to talk about today. Most people in hand surgery would use it for wrist arthroscopy, and the early papers suggested for simple debridement of the TFC that arthroscopic surgery was good. In fact, now, if you do an internet search on arthroscopic TFC treatment, in barely 0.5 seconds, you get 66,000 plus entries. So with that, I'll stop sharing and we'll bring on Tom Hunt, who will tell us about its role in the TFC.
Okay. Can you hear me? See my slides?
Looks good.
All right, thank you. Well, it's a true pleasure to be here. I'm gonna get back to the starting slide. Sorry, hold on. Okay, there we go. So my name's Tom Hunt, and I do have one of, I think, the simpler topics to begin with, and I'm thankful for that, Lee. And before I get started, I do want to let people know that anything I know about wrist arthroscopy, or really about wrist in general, is thanks to Dr. Osterman. And I say that for a couple reasons. First of all, as a thank you, deep-hearted thank you, but also so that any criticisms, critiques, or negative input regarding this presentation can be directed directly to Dr. Osterman. So with that, we'll go ahead and get started. So I think before we start thinking about treatments, we need to look at the anatomy and understand how the anatomy of the triangular fibrocartilage and its supporting structures, so the triangular fibrocartilage complex, actually results in its function. And its two main functions, of course, are to transmit load. You can see on the picture on the bottom left, with an ulna neutral variance, you transfer about 20% of the load that's generated through grip through the ulnar carpal joint and the triangular fibrocartilage. You can see there the disc, and you can see the radio-ulnar ligaments in blue. And
Tom,
also,
I think your presentation is not advancing.
you know, do you see it?
We're on
Nope.
the title slide.
Still.
Interesting. Okay,
Do you want to just close it out and try to reopen it?
I'll be happy to do that. I'm going to stop sharing, I think.
Okay.
Right?
You can blame that on Osterman too, Tom.
Well, undoubtedly. Okay. Do you see my slides?
Looks like they want to come up. They're not quite up yet. I see your name. And it said it's starting to share.
Okay. I apologize for this, audience.
We're still not seeing it. Do you want to try again?
Try again.
Thank you.
I'm gonna shut it down. And
would it be beneficial to switch the order of speakers? Lee?
Yeah, I think that we can. I was going to give Tom one more try and see if it comes up. If it doesn't, we'll switch to Will and come back to you, Tom.
okay, did it come up?
No, it's not. I think maybe you should log off and try to log back on during the while someone else
Okay.
speaks. And I think
Will
that might
do. I apologize, everyone.
Will, you want to come up?
I'll try. I'm a little scared after that. We'll see what,
Well, fine, in rehearsal, I can, like everything. Yay.
Good. We don't have your video, but we have your slides.
all right. Well, I can't, well, we'll go ahead. I don't know where my video went, but we'll go with, you can see the slides, correct?
Yes.
All right, so we'll talk a little bit about for wrist arthroscopy and a kind of a wide topic about carpal injury. I think we all know about the scapholunate ligament. The dorsal part is the most important part. It's very thick. It's stout transverse ligaments. It really plays the most key role in instability. The volar ligament's a little bit more oblique, and that allows the rotation that can, the slight amount of rotation occurs between the scaphoid and the lunate. And it's a very unusual ligament because it can stretch almost twice its length before it fails. And because of that, we see a spectrum of injury that can occur to this ligament. That's really, I think, it's helpful for arthroscopy so we can see the spectrum of injury and try to decide what to do with that. So years ago, we made a classification for this. For grade 1, just a stretch. And these are probably the normal wrist sprains. Grade 2, again, the ligament continues to stretch. If you go up the mid-carpal space, now you see a bit of a step off. Grade 3, now we start to see a tear, both from radiocarpal and mid-carpal space. And generally, the ligament would tear from volar to dorsal. And grade 4 was the complete tear. We could take the drive-through sign, we take the scope and go back and forth between the radiocarpal and mid-carpal spaces. So Lee's kind of going through this a little bit about the normal anatomy. This is with the scope in the 3-4 portal. So here you have a probe coming in through 6R, and normally between the scaphoid and the lunate should be a nice concave appearance between the two bones. It should not be convex at all. There should be no gapping. Like Lee said, you got to put the scope over in 6R to really see the lunate triquetrum. Again, a nice concave appearance between the lunate and the triquetrum with no gapping or step off. If you go over the mid-carpal space, it should be a nice, tight, congruent space between the scaphoid and the lunate. Here we got a needle coming in through the ulnar mid-carpal portal. Again, as you look at palpate between the scaphoid and the lunate, it's tight. There's no gap. There's no incongruency to that joint whatsoever in a normal wrist. You can follow the scaphoid up distally between the scaphoid and capitate and see the STT joint. Sometimes there's some air bubbles there. You can pop them loose with a needle. But you easily can see the trapezoid trapezium with a scope in the radial mid-carpal portal. When you look over at the triquetrum, they're normally about a 1 millimeter play. That's normal. Don't think that's an instability. So like Lee talked about, you need to go through both the radiocarpal and mid-carpal space to look for instability. If you go to radiocarpal space, there's no gapping. You go up, you may see a little bit of play, but that is a normal looking lunate triquetrum interval. Again, a nice tight interval between the scaphoid and lunate. That's normal. Now we're looking at abnormal. Now we're seeing some attenuation to the ligament. Now the ligament is bulging down. The lunate's to the right. The probe's in 6R. So this is an acute situation. This would be ideal for potential arthroscopic pinning. We can put some joysticks in to help control the interval between the scaphoid and the lunate. Again, we see the bulging ligament as seen from the radiocarpal space. But the best place really to do reduction is with the scope in the midcarpal space. So for a scapholunate, the scope being the ulnar midcarpal portal, we're looking across the wrist to judge rotation. We'll get an anatomic, and then we'll place the guide pins across. And as you place the guide pins, you can see the fat droplets. That confirms the pins are going from this between the two bones. We generally use 3 or 4 pins and we leave these in. Nowadays, we generally percutaneous will place a screw across rather than percutaneous pins. But that either option I think is viable. Now we're starting to see more of this is a grade 3 tear. Now we're starting to see gapping. The scope's in 3-4, the probe's in 6R. Now this will be a grade 3 tear. It tears from volar to dorsal. The dorsal part of the ligament is still attached, but we can see the gapping. We go up to the midcarpal space. Now you can see the incongruity. There's step off between the scaphoid wants the palmar flex. You can see that dorsal edge starting to flex, and you can see the gapping as compared to a normal wrist. So here's a partial tear. So you can see now the ligament, instead of being concave, is now starting to be convex, a little bit of bulging. So it's again a stretch of the ligament. It's not torn as a grade 3 tear, but more of a stretch. You can't see that as well with the scope in 3-4 as compared to earlier we just saw with the scope in the 4-5 portal. Now you go up to the midcarpal space, you're looking across. Now you're seeing more play. So again, we're evaluating this for both the radiocarpal and midcarpal space. Now we're seeing more play with the lunate and triquetrum as compared to the normal exam. Now we see with more complete tear, now we're seeing gapping between the lunate and the triquetrum. Instead of an intact ligament, a normal concave appearance. So for us, I think for the 1, 2, and 3s, I think these can be involved. I think for the 1s, we generally, that's more of a sprain. We treat that non-operatively. 2s and 3s acutely may consider placing a percutaneous screw. But the grade 4, we got a complete tear. I think that's the best option for open repair of this ligament, either between the scapholunate or lunate triquetrum. And I think the real key, Terry Whipple taught us there's a lot of big difference between acute and chronic tears. The acute tears, I think we can do arthroscopic reduction. Grade 4, again, an open repair. But chronic tears, obviously, it's very controversial. What do you do with these tears? But arthroscopy can help us identify this and help us make a decision. Peter Weiss years ago wrote an article on arthroscopic debridement. For partial tears of scapholunate, it worked out pretty good. Once you got complete tears, I think it probably didn't work very well. LT tears, there's less stress on that side. Debridement seemed to work pretty good in his hands for either partial or complete tears. I think we've looked at this. A lot of people have looked at for thermal shrinkage. I think thermal shrinkage really can work well in the wrist because you can immobilize it for a period of time, 8 weeks or not longer, to let that collagen mature once you shrunk that down. Particularly for chronic partial tears, I think this works extremely well. The key is, remember, it heats up the wrist. The wrist is a small joint. It can heat up very quickly, so you really got to monitor the fluid. So we really increase our irrigation. We monitor the probe. We monitor the fluid as it comes out. And when we do this operation, we want to shrink the interosseous ligament as much as we can, and also the volar and dorsal capsule over that area. You can look at it from the midcarpal space. You can see how you had a gap, then it closed down after the shrinkage. So generally mobilize these people for about 8 weeks, and a splint for 4 weeks, and then start range of motion. We looked at it, our study was a small tear. The grade 2 tears did very well. But once you get to grade 3 or grade 4 tears where there's a gapping, it didn't seem to work as well, which makes sense. So if you got these people that keep coming back, persistent pain, point tender over the interosseous ligament, partial tear, I think thermal shrinkage can work very good for you. Slack wrist, the condymalation kind of marks the spot where you need to resect. So here we're looking with the scope in 3-4. We see grade 4 condymalation on the scaphoid and the scaphoid facet of the radius. So we just come in with a shaver through the 1-2 portal and burr down the radial styloid. You can take up down about 4 millimeters. But the area of condymalation marks the spot where you resect that out. We'll move on a little bit to a distal radius. I think this is a very good option for wrist arthroscopy. You can view the joint in bright light, magnify conditions, take out any loose bodies, and this is a soft tissue injury just as much as a fracture. So you can look at the associated soft tissue injuries and manage these as well. Trumbull looked at various factors at looking at the best results for distal radius fracture, and articular congruity is one of the two highest factors. So that's where the scope can come in handy to get that joint surface as anatomic as possible. Soft tissue injuries certainly do occur. We've looked at this. Greg Hanker, Tommy Landau. Probably the TFC is the most common structure torn. That's why people generally hurt for 4 or 6 months, even if you get an anatomic reduction about the ulnar side of the wrist. But always think about a TFC tear if they continue to hurt down the line after fixation or closed management. What are the indications? Well, obviously, a radial styloid is a great one to do. Impacted fractures, those are very easy to do arthroscopically, but hard to do open. Die punch, 3-part and 4-part fractures can be done, maybe sometimes combining open with arthroscopic techniques. This is a perfect one. This was a very impacted radial, impacted scaphoid facet. So this is very easy to see arthroscopically, but very hard to do, I think, to see open. So here we got the scope in 6R. We're looking across the wrist. Here's our shaver coming in 3-4, and you can see that impacted facet. Again, this is very easy to see arthroscopically, but hard to see, I think, through open surgery. We try to do these surgeries between 3 and 10 days out. If you do a little bit later, it's hard to disimpact these fragments. So we kind of shaved out the debris. Now we come in with our trocar through the 3-4 portal and start elevating this up. We can use the volar lip as our landmark. We generally do these without a tourniquet. I still do wet arthroscopy. That's just me. I think to me it's still easier. And then we can close down that dorsal lip and lock that in. So I think we got that articular surface absolutely perfect. This was an older case. We still use pins rather than a screw. There was an interosseous ligament injury with that. So this is a true story. And this is Jackson, Mississippi, 100%. So this woman was a 40-year-old woman. She beat up her husband. She got arrested by the Jackson police. She got put in the back seat of her police car and somehow escaped and jumped over a bridge as she escaped with her handcuffs on. So you look at this, we had a scaphoid fracture. Obviously, we had the distal radius. There's a capitate fracture, and there was some instability to the lunar triquetrum. So arthroscopically, we came across and fixed the distal radius. Arthroscopically, we fixed the scaphoid. Percutaneously, we fixed the capitate, and then placed a screw across the lunar triquetrum. The rep was very happy that day. I don't think I got paid a cent because she went to jail, but it certainly was a very interesting case. That'd be her final x-rays. Scaphoids, again, I think this is very minimal to arthroscopy. Obviously, non-displaced fracture you can treat with a cast, but what a price. Muscle atrophy, contracture, you can lose your scholarship. Athletes could be out 6 months or longer with cast immobilization. Mosaic looked at percutaneous fixation of these fractures a long time ago. With acute fractures, a pretty good result, 89%. Delayed unions a little bit decreased. Sclerotic non-unions had a little bit lower percentage. If you do these arthroscopically, the best place to look at your reduction is with the scope in the midcarpal space. So if you have a waist fracture, it's best to see it from the radial midcarpal portal. If you have a proximal pull, you can check your reduction from the ulnar midcarpal portal looking across the wrist. Worked with Joe Slade quite a bit throughout the years. We kind of came up with a classification. Delayed presentations, I think these need to be fixed. The fibrous non-unions, we did a study. We just put a screw across. That worked very well. Cystic non-unions, I think you can fix with bone putty or bone grafting. Once you got a humpback, I think these need more toward open reduction as compared to arthroscopic. So this is a patient, it's very hard to find a 14 gauge needle. So if you use the small joint tubing, the 14 gauge needle comes in very well. So that comes in very handy for your guide wire, for a 0.045 guide wire. The scope is placed over in the 6R portal. We look across the wrist. We palpate the junction of the scaphoidal ligament to the proximal pole of the scaphoid. And right at that junction is the sweet spot. So we know exactly where our guide wire is going to go. We impale it. We'll bring our tower down. We'll look at with the C-arm. It's very reproducible. Now we just aim our guide wire toward the thumb and place our guide wire. Now we can check it in their different planes because it's a very C-arm friendly tower. So there we are in the AP. I think we're looking pretty good. Again, the starting point is very easy to get looking at it arthroscopically. There's the oblique, and there's the lateral. So through cannula, we'll go ahead and ream our scaphoid. We bring the guide wire out the volar aspect, so in case it bends or breaks, we get easy access to it. We can curette the non-union site through our drill hole. In this system, we're going to place some putty at the non-union site. So as you put it through a bone biopsy needle, it comes out in a cylinder. We'll just place it over the guide wire. We'll check its position. We push till we get resistance and place our screw. There's our reduction. Maybe we could use a little bit longer screw, but I think it went across. Now we go back to the microbial space, evaluate our reduction. I think we got good compression. There's no rotation to the fragments. So we got a good reduction. So this is how not to do it. So this patient had a previous reduction to the scaphoid. You can see the screw is a little bit more radial. The patient came in and had a distal raised fracture. This got a chance to look at this. And so you look at it arthroscopically, and the screw wasn't fully inserted into the scaphoid. You always got to go back and check that screws up into the scaphoid. And on to the right, you can see where it eroded the articular cartilage on the scaphoid instead of the radius. So here we repositioned the scaphoid screw, oscopically fixed the distal radius. Let's hopefully give him a second chance with this particular injury. And I appreciate your attention. Thank you very much.
Thanks, Will. Appreciate you covered a lot of material. One of the things that always has troubled me, we talk about wrist arthroscopy as the gold standard. But when we did a study a few years ago where we sent videos to people of your stature, we found the agreement rate was only about 80% between known arthroscopists of the wrist, and where most of the differences were in the soft lesions, what you called your Geisslers 1 and 2, the peripheral TFCs, whether they're really torn or lax. Do you find that there is a lot of variability in some of these lesions that we identify? Because we say the wrist hurts, there must be some reason, or do you think it's just it takes a lot more cases to get a sense of laxity under your belt?
Well, I think, I mean, you look throughout the years, when you see people reproduce your classification, it gets changed a little bit sometimes how you originally described it. I still think that the wrist scope is the best way to look at it. I think like you say, you got to evaluate both in the radiocarpal and midcarpal space. And then the treatment algorithms we gave was years ago. I think like in distal raised fractures, we don't have to treat all these soft tissue injuries we saw initially. I think with the bleeding from the fracture, I don't think we need to pin these grade 2s, maybe not the grade 3s. I would still work and address a grade 4 if associated with a distal raised fracture. But the whole idea of the classification is what you see arthroscopically. It doesn't mean what other extrinsic ligaments are torn with it. It's just a pure arthroscopic classification.
Yeah, but I've come to believe that sometimes my arthroscopy works because they're partial lesions, et cetera, even though they've failed non-operative before they've gotten to me. Whereas when we get to more static lesions, as you pointed out, it works less well. I will say that PC Ho and Paco Penal in Europe and in Hong Kong, respectively, are pushing the envelope, and they are reconstructing the static lesions with arthroscopically assisted, where they're using sort of box stitches, and their results are quite impressive overall. Tommy, are you alive and ready to share?
Yes, Lee, I'll try again. I think Mackenzie's going to try and run the presentation from her machine, so we're going to go that route. So next, please, Mackenzie. So as mentioned, we're going to go ahead and dive into triangular fibrocartilage and complex tears. And as I was mentioning, anatomy informs function, and we know that the TFCC transmits load. But I was starting to say last time that it also stabilizes the joints, especially the distal radial-ulnar joint, by virtue of the dorsal and the volar radial-ulnar ligaments you can see there on the right drawing, and the ulnar carpal joints. So the volar ulnar carpal ligaments there on the bottom on the right drawing, those two are the primary structures, I think, that provide stability, but they all contribute. And understanding that truly it is a collaboration of supporting structures is important as you think about treatment, and also as you think about some of the secondary problems that can occur from these injuries. Next, please. It's also important to understand the anatomy from the perspective of vascularity and also histology. You can see on the bottom left, Mike Bednar years ago did an injection study which really informed us that the peripheral 30% or so of the triangular fibrocartilage was vascular. And as we know, repairs or other methods designed to heal typically require vascularity. And so repair on the periphery and debridement in the central portion that's avascular is kind of the norm now. It's also important to understand histology. So you can see here the triangular fibrocartilage disc as it inserts into the radius in the middle. And really the fibrocartilaginous disc is inserting into hyaline cartilage. So there aren't any blood cells, there aren't nerves, there aren't lymphatics in this attachment, as opposed to the radial-ulnar ligaments, which, as we know, originate from a broad attachment in Sharpie's fibers on the ulna sulcus and fovea, and then proceed from there with contributions from fibers from the ulnar styloid base over in a radial direction, inserting into the radius both on the volar and dorsal aspect. But this time their insertion really is through a fibroosseous transition, as you can see, into bone. So very different, in an area that potentially is responsive to repair. Next, please. The other thing to recognize is that stabilization, though a critical function of the triangular fibrocartilage, is also contributed to in a significant way by the distal oblique bundle of the interosseous membrane. We found that in about 40% or so of patients, this distal oblique bundle is present. And in those patients, even without the supporting volar and dorsal radial-ulnar ligaments, the distal radial-ulnar joint can remain stable. So just examination of stability and assessment through physical exam and x-rays won't necessarily tell you what needs to be done, but it's important to recognize this component as well. So next, please. But if we look at physical exam assessment, we think of a few things that are pretty classic. One is foveal tenderness, and I'm pointing to the fovea right now, consistent with triangular fibrocartilage tears, especially peripheral tears. Instability, as you're seeing now with a simple shuck test in neutral position, in full supination and full pronation, and obviously in comparison to the other side. And also other findings, like, for example, ECU subluxation, which you see occurring here as well. One other physical exam finding that's commonly utilized is the piano key sign. Next, please, Mackenzie. And pain with ulnar deviation, or the TFCC stress test, is a workhorse exam, of course, which is very sensitive, but not particularly specific to triangular fibrocartilage tears. Next. So imaging is a critical component, and I think it helps us in many ways. It helps us look for other injuries, but also to characterize the triangular fibrocartilage injuries. Here you see an NHL hockey goalie there on the bottom left, who had a subsheath, ECU subsheath tear. You can see it being fixed on the right, and that MR arthrogram, I think, really informed our approach in that particular patient. And you can see just with plain x-rays on the top right, for example, there's widening of the distal radioulnar joint, and that was in comparison to the normal on the other side. Again, a sign of instability. And just sometimes you see strange things like this triangular fibrocartilage that's interposed in the DRUJ and is pulled off its site of insertion. Next, please. But it's also important to understand that when you look at distal radioulnar joint instability, like you see here in this 14-year-old, it's not always related to the wrist, the TFCC. This is a patient who, you can see the incision over the dorsal ulnar wrist, had a previous TFCC repair, and predating that had a both bone forearm fracture, and clearly it was the position of the ulna that was responsible for the distal radioulnar joint instability. That corrected with osteotomy and internal fixation. Next, please. Andy Palmer was kind enough to provide a classification tear for us a number of years ago, and this is it right here. Class 1A tears are in the non-vascular portion there at the top left, obviously not amenable to repair. Class 1B is more peripheral, and we'll see as we go through a couple patients that can be variable in terms of its effect on stability. Class 1C involves the ulnar carpal ligaments there on the bottom left, and then 1D involves the disc as it inserts into the radius, as well as potentially involvement of the radioulnar ligaments as they insert. Next, please. So this is a patient, 39-year-old female, avid but amateur tennis player with pain after an aggressive match, seen in Mississippi, actually, and had persistent right ulnar-sided wrist pain despite appropriate activity modification, cortisone injection, etc. Good treatment. On physical examination, this patient had some mild but not particularly impressive foveal tenderness. She did have a positive TFCC stress or grind test, as was demonstrated, and no evidence of instability. Next, please. Here are her x-rays. Grip view shows us ulnar variance is neutral, and we can talk about the impact of ulnar variance and how people think that might affect treatment. But in her, it was neutral. You can see her MRI scan reveals a class 1A tear, and you can see the drawing, which emphasizes what the tear was like. Next, please. And this fairly simple injury is in the avascular portion. You see it here. Classically, it's a dorsal volar direction. You can see on the right series of images, top, that's what you see at the time of arthroscopy, looking through the dorsal 3-4 portal. It's amenable to debridement, as you see in the bottom, and then complete debridement on the bottom right. And this patient returned to her normal activities. Next, please. Patient 2, this is a 47-year-old lawyer, philanthropist, who was skiing. I think probably close to Dr. Osterman somewhere, I imagine. He fell skiing. He sustained right ulnar-sided wrist pain. And when I finally ended up treating him, it was about 6 months after the injury. I had seen him initially just 10 days after the injury and started conservative management. Eventually figured out he was going to need surgery, but he delayed treatment for several months. When he finally did have treatment, he had foveal tenderness. He had a positive TFCC stress test. Everything was pointing toward a peripheral TFCC tear, especially given the fact that he had some instability on shuck testing of his DRUJ. Now, I kind of labeled this as moderate, and I think it's a continuum. And in his case, he had mid-position laxity and discomfort with that stress, but had a tightening of the distal radial ulnar joint similar to the contralateral side in full pronation and full supination. And he had a mild piano key sign with normal x-rays. Next, please. So here's his MRI scan. And you can see on these coronal images, he's got some scarring. He's got injury to the peripheral portion of the triangular fibrocartilage. Now, I can't tell from this whether it's the deeper fibers, those that provide the greatest stability, the insertion side of the radial ulnar ligaments, or more superficial, more capsular fibers. And clearly it's a continuum of stability. So every type or class 1B tear such as this isn't terribly unstable. His was somewhere in the mid portion of that. Next, please. And so here's his arthroscopy. You can see us through the 3-4 portal. And then you can get under the periphery of the TFCC, clearly a peripheral tear. Next, please. And here's kind of a standard outside-in repair using 2 needles, very, very standard approach and very successful, but a capsular type repair. So one in which I would utilize in a situation such as this, mild instability and associated pain. You see his final result on the far right. Next, please. If you look at a variation of this, and again, it's a continuum, and this is a 19-year-old college basketball player, his dominant right hand. He was 18 months out from a wrist injury, originally diagnosed with ECU tendonitis and treated as such until finally his ulnar styloid non-union, visible on the bottom left, became obvious to folks. And so we obtained an MRI scan, and you can see the arrow is pointing to a destabilizing peripheral TFCC tear, and his examination was consistent with a significant lack of stability in all positions. And you can see what's happened to him on that axial MRI image. We've already got degenerative change related to that peripheral tear. And we had some other secondary changes that we'll see here in just a second, but you see how his ulna is dorsally prominent here as well. And you can see actually on the axial MRI, the arrow is pointing toward the remnant of his ECU tendon, which is now subluxated and scarred. Next, please. So these are his operative images. You can see on the far left, the scissors are in the ulnar styloid non-union, and the pickups are holding the scarred and subluxated pseudotendon of the extensor carpi ulnaris. So this is one that clearly required an open treatment, and in my mind required a more substantial repair to bone at the level of the fovea, as you see in the middle. And to help support this repair, we also performed a palmaris longus tendon graft and stabilized that dorsally to help with the secondary stabilizers, that portion of the triangular fibrocartilage complex. Next, please. Patient 3, again, a collegiate athlete, 21-year-old baseball player. This kid is a first baseman and a home run hitter. He presented with right ulnar-sided mechanical type pain, especially with his sport. He was 1 year out from arthroscopic debridement for what was termed a type 1A tear. His examination revealed some discomfort with TFCC stress, tenderness over the ulnar fovea, especially slightly volar to the fovea, a little bit closer to the flexor carpi ulnaris, Again, no instability and normal plain x-rays. Next, please. Here's his MRI scan. You can see this guy's kind of been ridden hard and put up wet, so to speak. He's got some degenerative changes at the proximal cartilage area of his triquetrum, as evidenced by the blue arrow. And you can see there's fluid that's leaked out volarly, and he's got either a volar cyst or a synovitic cyst present. And so with this person, next please. We took him to surgery, and this is a variant of a class 1C tear. So class 1C again involves the ulnar carpal ligaments, as you see at the top right. But this was a longitudinal split tear as described by Dick Berger and others. And you can see the bottom left, the typical injection of the volar ulnar ligaments is seen through the dorsal 3-4 portal. That was debrided, and then subsequently an incision was made, a longitudinal incision between the fovea and the flexor carpi ulnaris. That synovial cyst was resected, and an outside-in repair of the split tear was performed, kind of similar to how this drawing depicts it. And he returned to his sport and was the all-time home run hitter for that college. So that was a nice result. Next, please. Finally, class D tears. Dr. Palmer described these as traumatic avulsions of the TFCC from its attachment to the radius. In speaking with him, he really considered this not to be a destabilizing injury, but rather to be just a very radial class 1A tear. You can see a typical MRI depiction there. Next, please. And so Dr. Palmer really was thinking of the bottom left picture, where you see the central disc attaching to the radius. Again, though, a cartilaginous disc attaching to hyaline cartilage. So not a lot to repair to in my book. Next, please. And this video was provided by Michelle Carlson. You can see this one has the central disc involved, but also a portion of the volar radial ulnar ligament. You'll see just to the left, and you can see the instability. She stresses the DRUJ. And then finally, when I've seen this be more destabilized, I haven't seen it in this manner. I've seen it associated with fractures, as you see at the right. So kind of like a class 1B tear or even a class 1C tear. Class 1D tears provide a stability continuum, and in that way, do inform the kind of treatment that, in my mind, should be rendered. Next, please. So if we look at these tears and treatment outcomes, most often, to me, these are not destabilizing tears. And if you look at the literature on open repairs, arthroscopic repairs, and actually Dr. Osterman's discussion of arthroscopic versus debridement, really, they're all about the same. And from my perspective, these are best treated by debridement unless destabilizing in nature. Next, please. This is my final slide. And really, this just shows that if you do have a peripheral component to your class 1D tear, that probably reattachment, some sort of stabilizing procedure might be indicated depending on the clinical examination. So I thank you for your attention. I apologize again for my earlier misstep.
Tom, while Rob is setting up, what do you think of the two? I mean, the TFC gets blamed for a lot of ulnar wrist pathology. What, in your opinion, are the two most common diagnoses that are missed for the that and are blamed on the TFC? I think we should have examples of both. Yeah,
I think there are so many because the TFCC is so commonly associated with other injuries. And, you know, this test that I described, the foveal test, the TFCC stress test, both of those can be positive with scapholinate ligament injuries, for example. And they're just not terribly specific, but quite sensitive. I think, you know, I think you have to think of more chronic issues. You have to think of impaction. We know, for example, that with a non-destabilizing 1B tear, that an ulna shortening osteotomy will probably give you just as good a result as a peripheral repair. At least that's what the literature would imply. And so that tells me, well, maybe we're not diagnosing that correctly. So I think there's I can't give you two, Lee. I would probably say some impaction syndrome type thing, or an intercarpal ligament disorder.
Well, in my book, we
I'm
looked
sorry,
at,
one other thing, obviously tendonitis.
well, we looked at a number of failed, quote, wrist arthroscopy TFC debridements. And I would say the two most common diagnoses on the ulnar side of the wrist were ECU subluxation, which wasn't appreciated, and foveal instability tears, where they did superficial repairs rather than appreciate the foveal detachment. And those seem to be, I think, the major missteps that people made. Rob, are you ready to share?
You know, I think while he's doing that, Lee, I would agree, and that speaks to the value and what you taught me about physical examination. I mean, that's really, those things really speak to the value. So thank you.
Thank you. And now we'll have Rob Wysocki talk about how to approach the other common reason for wrist arthroscopy as shown by most hand surgeons, which is ganglionectomy.
Great, thanks. Can you guys see my slides?
We can.
Okay, all right, perfect. If anything goes wrong with me advancing, just let me know. Well, my charts today, arthroscopic ganglionectomy. I'm going to focus primarily on dorsal carpal ganglions just to keep things pure. And we're going to talk a little bit about some of the technical pearls that have come out of several of the papers that have been published, and also delve into the evidence a little bit supporting arthroscopic ganglionectomy compared to open, and even look at a little bit of the evidence on non-operative management as well for what is a pretty common condition that we treat. So first, just to highlight a few of the papers that brought out, I thought, some decent technical pearls. They're listed here, but I'm going to go through each of them a little bit individually. The first, which is by Wu and colleagues from 2019, introduced or popularized this concept of a trans-cystic portal, as opposed to a cystic sparing portal, like a 3-4 portal that's placed around the cyst. A trans-cystic is started by an 18-gauge needle directly through the cyst, and then you can introduce an arthroscopic shaver through it. And when you look at their studies, a minimal difference in extensor tendon complications, but the one larger difference is 0 recurrences for the trans-cystic portal and 8% or 2 recurrences in their series with a cystic sparing. So a little bit of a newer concept there, but could benefit from some further study. The next study there listed by Sue and colleagues, this is actually a pediatric study, but really highlighted the value of using some sort of a dye to help show where the cyst is, and especially where the stalk is. That image that's shown on the left side, the blue part on the left is where the stalk would be emanating from the scapholunate ligament. And again, this was a pediatric series, but it really can translate even into the adult and using the similar technique. The study by Asen, the third one, this was Asen and Jeff Yao out of Stanford, looking instead of methylene blue, they looked at indigo carmine, but showed results of it for an arthroscopic ganglionectomy. They had a series of 27 patients, just 1 recurrence, as you see there, and they echoed that they could visualize the stalk in 100% of their cases once they had injected the indigo carmine dye. The study I just quoted was from them in 2015. This is actually their first publication of the technique in 2011 as a technique paper. A couple pearls to highlight. You can see on the left, they have a nice circle drawn around the cyst. And I would encourage you to definitely do this prior to any insufflation or starting your wet arthroscopy, because you can really start to lose cyst is if you don't do that first. So I would recommend doing it. They've now started a 6R viewing portal, and that's where you're looking through in the image on the right. a needle's being introduced and where a 3-4 would be, and you kind of have a faint visualization of some clear ganglion cyst fluid. Once the 6R is started, an 18 gauge needle can be placed into the cyst. If you're not sure if you're in it, you can pull back a little bit of the jelly fluid to make sure you are in, and then inject your blue dye. And now you can see the color of the cystic material, the stalk, has been changed to a more visible blue. And then the arthroscopic shaver can be inserted either through the cyst or through a separate adjacent portal to be able to do your debridement down to healthy capsule and healthy scapholunate ligaments. So I think this is a nice technique to use a dye for these cases. So if you haven't tried it, I would recommend considering it. The fourth of the technique emphasis papers, this was by Gray and Srinivasan out of San Antonio, and they advocated for considering dry wrist arthroscopy in these cases. You can see here from two of their tables, they discuss some pearls and some advantages or disadvantages. I don't necessarily agree with all of them, but I'll highlight what I think are probably two of the truest advantages, which is the benefit of avoiding fluid extravasation and swelling from dry arthroscopy, which can lead to an easier conversion to open surgery if necessary. So if you think there's a reasonable chance of conversion, may be wise to first start doing it as a dry scope. As far as downsides of the dry arthroscopy, I would agree with these two. I think it does place you at risk of an incomplete cyst excision. I think the reason is, as Lee highlighted briefly in his talk, the stalk for a scapholunate origin dorsal ganglion tends to be all the way at the distal end of the dorsal band. And the capsule can sometimes fall down and block your view if you don't have insufflation or scope fluid. So if you're going to do a dry, you want to make sure you're really looking up or distal to make sure that you're really appreciating where the whole stalk is. And then theoretically, as the extensor tendons fall back towards the wrist joint under less insufflation, they may be at greater risk, although that's certainly quite theoretical. Looking a little bit into some of the data we have as far as pure case series on arthroscopic ganglionectomy, and I know this is a bit of a busy slide, but we'll just briefly go through each of these individually. And this goes from recent to older. The Fernandez series described there used the most common technique of the viewing portal in 6R, the working in 3-4, a case series with a nice 4-year outcome, 34 patients, only 1 recurrence, 3%, and 1 minor complication of hypertrophic scarring. We go down to the Edwards paper from 2009, exact same portal technique of the 6-4 and the 6R and the 3-4. A larger number of patients, 55, but only 2-year outcome. One thing they commented on here, which is commented on in several other studies that I'll highlight, is the presence of the stalk seen arthroscopically. You can see they state they only saw a stalk in less than 10% of their cases. Now remember, in Yao's series, it was 100%, so a stark difference. Although Edwards and colleagues comment on another 38 cases of a capsular thickening that looked pathologic, which would bring you up to 42 out of 45 seeing pathology. So I think this could get down to a matter of semantics and what's defined as a stalk. But there's very differential reporting in the literature as far as how often a stalk is seen. Regardless of whether it's visualized, recurrence rates still seem low. So they had no recurrences in this series and just 1 case of persistent swelling. When we go down to Marco Rizzo's paper from 2004, a little different in that they employed a 4-5 instead of a 6R portal, but a nice 4-year outcome similar to Fernandez, 41 patients. And they, much like Edwards, saw the stalk only a fraction of the time, 29% visualized. And yet despite that, only a 5% recurrence rate with 1 case of persistent swelling, much like Edwards had. So low complication, low recurrence. The last of these studies, Nishikawa from 2001, this is really the one study where they switched things around. So their viewing was all the way on the radial side. They made a 1-2 portal for their viewing, which, as you know, can be a little bit dicey to start. You probably want a bit of a bigger open incision, make sure that the radial artery and dorsal sensory radial nerve are safe. But they were able to do it safely, 39 patients, a shorter follow-up, just 20 months. And they, much like Marco's study, only 21% where they saw the stalk, although they then describe a compressible pathologic appearing synovium in another 19 patients, which was 49%, which jumps up to then about 70% where they saw something that looked abnormal versus 26 not. Regardless, again, a low recurrence rate of only 5%. So that's what we get out of the case series. You might say, well, what about open case series? What do we know? Well, it's interesting. quite a paucity of data as far as pretty uniform, large series of open ganglion cyst excision. These are really the two largest and best studies. Balaz, this was more recent, 2015, a military study where they found a 9% recurrence rate at nearly 4 years. And interestingly, they did find that having dorsal wrist pain with extension loading at over 4 weeks was predictive of that as a more long-term problem, which is maybe some useful information for us to know in counseling our patients, whether we do it scope or open, because that's oftentimes the one driver of having this surgery for patients outside of cosmesis is dorsal wrist pain with extension loading. The study by Diaz, much more grim as far as the outcomes. Again, over 100 patients. This was from 2007. You can see a high recurrence rate of 39% in over 100 patients. This was at 6-year outcome compared to 4 years in the previous study, and a few more complications. So nerve-related and then 5 scar-related complications. So quite variable outcome there between 9% and 39% recurrence. Well, what can we learn from some comparative studies? And that brings us to the study by Lana Kang and Peter Weiss, probably kind of a hallmark as far as any comparative, or I'm sorry, landmark as far as any comparative dorsal ganglion studies. 2008 randomized controlled trial, outcome at greater than 1 year. They saw the stalk in 100% of their cases, again, echoing some of that variability that people report. They had pretty similar recurrence rates, 10% in the scope cases, 9% in the open, no statistical difference, and only 1 dorsal sensory-radial nerve irritation case within the scope group. And then the second study there to comment on, this was by Head and colleagues. It was a bit more recent, 2015, a combined systematic review and meta-analysis. For the meta-analysis component, 2 RCTs and 4 cohort studies, although only one of the RCTs was able to address recurrence. Another 35 that contributed some data to the systematic review. And if we focus on the recurrence data, a pretty large subset of patients, 809 open, 512 arthroscopic, and numbers that really echoed some of the case series. So only a 6% recurrence in arthroscopic, 21% in open. Complication rates primarily scar or swelling related, a little bit higher in the open group, although they were not major complications. So this slide just kind of summarizes all the arthroscopic data, adding in Kang's work. And you can see stalk visualized overall 38% of the time with quite a bit of variability. You can see the technique that they used, and where that recurrence lands us is close to Head's number of 6%, lands at 5% for all these studies. Just briefly to summarize a little bit of data on non-surgical treatment. I think this is a nice paper to review if you have interest in it. This one by Meena and Gupta, which was a systematic review. And really these 6 studies that are highlighted here, if you look at that average number at the bottom, suggest about a 50% spontaneous resolution as far as the natural history of dorsal ganglions. And that's at outcome, as you can see, anywhere from 2 to 12 years. Nevertheless, it appears 50% of those might purely go away on their own. The question's time. Do we get any benefit from adding a needle in any way? So you can see in this, I think, nice table that summarizes numerous studies. If you look in the second column and look for that average number, aspiration average 41%, aspiration and steroid 52%. So it appears that recurrence with any introduction of a needle, plus or minus steroid, hyaluronidase, a sclerosing agent, adding splinting, that recurrence rate still seems to sit somewhere in the 40s to 50s for a lot of these, almost showing not much benefit over just benign neglect alone. And it appears on the bottom that aspiration with multiple punctures might even make us a little worse. So it really gets down to how we decide to manage these non-surgically. As common as these are to come into the clinic, I imagine a lot of us do very different things despite what the literature says. So briefly, in conclusion, comparative studies, unfortunately, are really still lacking, as are surprisingly general outcome studies for open surgery. I feel like we're actually maybe a little bit ripe to have, for those who support open ganglionectomy, maybe some larger or better studies looking at open, since the results look relatively poor. There's really no agreement on the best technique, although the most common would be that viewing portal through the 6R, and likely a 3-4 working portal, or maybe a trans-cystic working portal. The recurrence appears to be 5% through the scope, and maybe somewhere at or over 20% for open procedures. So as I think of controversies or questions to discuss, for me, it's a few things. Number one, is there a different management strategy for the occult versus your more obvious lobular dorsal carpal ganglion cyst? Personally, in my practice, I find I take out more occult cysts than I do the large obvious ones. And sometimes I think that the occult cyst is almost like an amoeba that's kind of stuck on the dorsum of the joint, almost gets stuck like a rug under a door when the wrist comes into extension, maybe compared to the more large, obvious lobular ones that are more cosmetic than anything. Another question, the trans-cystic versus cyst sparing. I have tended to use the cyst sparing, but I'm kind of intrigued to know if others have tried trans-cystic dry versus wet arthroscopy. I use wet arthroscopy here. I don't know if others have pearls to offer. I do think that the dye technique is quite nice, and if you haven't tried it, I would recommend considering it. What is the true incidence of a stalk, and does it matter? It probably doesn't. It probably doesn't. When you look at the studies, the recurrence rates were uniformly pretty low despite whether a stalk was seen. As far as non-operative, what is the best strategy? For me, I think some of it is how much the person really dislikes the look of it, or if it's causing quite a bit of pain, where if it could even temporarily deflate, they would feel better off either by the appearance or secondary to pain. I think that person maybe aspirate. If it doesn't bother them all that much, then probably true benign neglect without aspiration is just as good as sticking a needle in it. Then, of course, lastly, the scope versus open debate. And it's interesting because even though the data clearly supports a lower recurrence rate for arthroscopic, I had polled before we started, I polled our faculty here, not just the faculty for the arthroscopy session, but all the faculty here on this AO session. And about 2/3 favored open. And interestingly, everyone estimated their recurrence rate was at or well below 5%, which is interesting because the literature would support over 20%. Big difference. And granted, that's people estimating their own, and there could be some patients lost to follow-up, but I think there's a little bit of a disconnect between what we think our recurrence rate is open ganglionectomy and maybe what it actually is, or maybe it's technique dependent on who published the papers. So I'm almost done. I just wanted to show a few kind of like case slides. This patient, believe it or not, has a dorsal carpal ganglion cyst. For me, this is the kind of typical or early 20-something-year-old. This is a male, comes in complaining of extension loading pain on the mid-dorsal wrist. You don't see a cyst at all when the wrist is in neutral. When they hyperflex the wrist, you see a little something. You probably won't believe me because this is two-dimensional imaging, but there actually is an ever so tiny bump on this kid's wrist. And then when you get an MRI, this is what it looks like. You see that somewhat kind of amorphous a high T2 signal lesion on the dorsum of the wrist. If you look at the video that I'm going to animate here for these axial sections, as we go distal, that was the radius and ulna. Now the scaphoid and lunate are just coming into view. You see no cyst, right? So there's the dorsal band, but there's no cyst. Still no cyst. We're going distal. You're just starting to see the cyst come in, and right when you hit kind of the beat for the capitate, now you see the cyst. All right, and I think that it highlights an important point, whether you're doing these arthroscopically or open, that the stalk is going to be relatively distal along that dorsal band of the scapholunate ligament. It's kind of where there's the weak point. The weak point is not the thick dorsal band. And I think that that black structure below the cyst on the axial sequence, I believe that's the dorsal intercarpal ligament. So I think if you're going to be doing these arthroscopically, you probably want to be careful not to really aggressively debride deep to the cysts because you may compromise the dorsal intercarpal ligament. How much does that matter? Maybe not much. But I think you can see on this schematic where that DIC runs across is right below where that ligament very well may be. So for me, when I do these open, for example, I'll open up half of the distal portion of the extensor retinaculum, much like is seen in this image, the distal half missing. The cyst is usually going to be sitting right about there. And then I'll put a retractor between any of the digital extensors to get down to the dorsal capsule. And usually a release of just maybe the distal 30 to 40% of the retinaculum is enough just to be able to get access to that distal part of the SL right where it meets the mid-carpal joint for the resection at least open. So I'll probably pause there. Just one other thing I wanted to highlight. It's not a ganglion, but make sure you don't confuse it. This is a 60-year-old woman came in with what could have been confused for a dorsal ganglion. If you always want to have in your mind a extensor tenosynovitis in these patients, you want to have them range their fingers, wiggle their fingers, see if the swollen mass moves with finger motion, because this is going to be a very different animal. It doesn't always look like this classic rheumatoid one. It could be much more more subtle. Like you can see this ganglion on the left doesn't look all that different from the extensor tenosynovitis case on the right, which if it becomes surgical gets a much different treatment, right? So this is an entirely different animal that you're getting here with the dorsal extensor tenosynovitis than you are with just simply a ganglion cyst. So I will stop there. Thank you.
Thank you, Rob. While you're changing, a couple things that I would only add. One of my favorite talks I give is why I hate the dorsal ganglion, because it's so easy to diagnose and people think, well, it should be simple. But when I was your age, taking out a ganglion, you ended up with a pretty good scar on the back of your wrist, often some stiffness and volar flexion. And so your pain with dorsiflexion became pain with volar flexion often. And so I always think that wrist arthroscopy matches the pathology to the surgery, and if you will. It also gives you a chance to look around the wrist, which often you'll find other things in the wrist that are often the generator of fluid, which may influence the ganglion. There are a couple questions about cysts and whether you use the dye or not. One of the problems with the dye, I think it is a good technique, but getting the dilution, you want to dilute it so it's almost clear. Jeff Yao, who was my fellow when we did this technique, we found you colored so much blue that you were at risk, if you started removing everything blue, of taking out some of the scapholunate ligament. So it tended to make you more aggressive because more things were dye colored. As to trans-cystic, there are some ganglions dorsally that have origins also from the mid-carpal joint. And so if you may miss that by going trans-cystic. So I tend to do a non-trans-cystic approach, as you mentioned you did. How about volar ganglions? Do you do those arthroscopically?
No, it's a good question. I don't. I get very concerned about the vasculature nearby. I just, having known so many of these I've opened and the radial artery is just twisted around the thing. And I just think in general, volar wrist arthroscopy for me is a little bit dicey. So I haven't. But I imagine there's that way to just get the stalk at the level of the capsule and not even really have to worry about the artery because you're just getting it from the inside out. So I could see some value, but personally, no.
That's always been my argument, because when you open them, you often struggle around the radial artery if there are things. And if you do just between the radioscaphocapitate and long radial ligament, that's where the ganglion arises from, or occasionally in the mid-carpal joint, the triscaphic joint if there's some arthritis. And you can actually get to the ganglion from a dorsal arthroscope.
Lee, do you image those patients preoperatively to know that they're not one of the more distal ones coming from the STT joint?
I don't. I don't use any advanced imaging in most arthroscopic cases. I would add that if you look at the literature, while wrist arthroscopy has low complication rates, some of the extensor tendon injuries which have been reported either as case studies or having been referred personally are in recurrent ganglions because the tendons get somewhat displaced and irritate your portals. So I would say that's it. We're running a little bit slow, so let me share my screen and talk about wrong talk. Let me stop sharing. Share screen again, and this is the talk we want. Thanks. Well, I'll try to go pretty quickly so that we have time for cases here. Basically, I assigned myself this topic because I think this is one of the more commonly missed diagnoses. In fact, unlike some of our previous speakers, I don't have 4 or 5 pages of literature to show you the outcomes. And so it's a diagnosis which I still find many hand surgeons are either unsure about or that they miss. And this is lesions of the ulnar extrinsic ligaments. Remember, these are the ligaments which Andy Palmer kind of defined as an overlap between his 1C or volar area of the TFC, but they do not involve the TFC, which is stable, particularly the volar radio-ulnar ligaments. And so they're part of the triangular fibrocartilage complex, but they cause no distal radial ulnar joint instability. They have nothing to do with the distal radial ulnar joint. And you can see them drawn out schematically. We can't see the ulnocapitate ligament, which is deep to the ulno-luno and ulno-triquetral ligaments, unless there's a tear. But here on a normal wrist, you see the prestyloid recess, you see the LT, and you see this very nice sheath of ligaments. You can see them on an arthrogram. This is a normal one, a 3D MR arthrogram. And we can see the ulno-triquetral ligament, which is a little more volar than the ulno-luna. You can see it on the ultrasound if you want it. It runs in a fairly nice pattern between the triquetral and the ulna. It's one of the most common injuries in the wrist because it's a torque injury, and so it's going to be common in golf and in almost all racket sports. There are really two types: the split ulnar extrinsic tear, which is one that Tom Hunt mentioned. And then the second type is a more ulnar avulsion where the whole area comes off, and that usually is associated with ECU instability as well. How common is this? Dick Berger has really been the champion of this, and he taught me and has shared many of our thoughts on this in his large series of a number of diagnostic arthroscopies. It accounted for 18% of the lesions that he found. And this was this tear between those two ligaments, which is where the torque tension goes on the ulnar side of the wrist. Again, I just want to emphasize always, I don't care if you're doing wrist arthroscopy or open, if you have ulnar wrist pain, do and examine the ECU for ulnar subluxation because it's intimate with the TFC peripherally and with the distal radial ulnar joint. So here we have a typical case, a 22-year-old ice hockey player, collegiate, twisted his wrist during a slap shot. Ulnar pain, but not the kind he couldn't play with. But over the next few months, he couldn't put any force into his shot. Now, this isn't his injury, but it kind of emphasizes that while this obvious injury to the distal radial ulnar joint is obvious, you have to be more subtle in these exams. And here, they're going to have tenderness on the ulnar and volar side of the wrist. They may have a positive TFC test, as Tom showed, but they have this carpal supination deformity as opposed to distal radial ulnar joint. And he brought up the fovea sign. The fovea sign, as Dick Berger has shown, has a high sensitivity and specificity for ulnar extrinsics. And so when I examine someone's wrist, I basically use that soft spot just dorsal to the pisiform and beneath the ECU, that soft spot, that's the fovea. And if you look where you're putting your finger, you're right over the ulnar extrinsic ligaments. And I find that a sign for ulnar extrinsic and not for TFC, which is generally going to be more dorsal when you're examining it. And this just emphasizes the positivity of the fovea sign and its correlation with ulnar extrinsics. The other thing, aside from a fovea sign, is you will often see a little bit of a carpal sag if you load these wrists. It's not just the radial ulnar joint, just the radial ulnar joint is stable. It's the ulnar carpus which supinates away from the wrist. And so here's a patient with, you'll notice what was called a normal arthrogram back in the day, but filling the piezotriquetral joint particularly easily may suggest that you do have a defect in the floor, which allows you to see the piezoform easily. Little increase on the triple phase bone scan and an altered signal. When you do an MRI, that cyst that Tom described, that's fluid which is pocketed beneath the torn ulnar extrinsic ligaments. But unless you have a good MRI and a good musculoskeletal radiologist, it's frequently not called. At arthroscopy, it's obvious. On the top left, you see a normal. You have an LT where the probe is, but the ulnar extrinsics create a solid floor. And from the piezotriquetral recess, there should be, you should not fall, as we see on the lower left, directly into the piezotriquetral joint. So here we have a patient with a split tear. We're looking from the radial side of the wrist. The probe is down in the 6R. We'll try to clear things out here in a second. This is real time. And as we start to come down the prestyloid recess, you're going to see behind all that fringe. And we're just going to literally, you'll see this kind of defect between the two fibers where the ulnar extrinsics are running. And it's a fairly easy diagnosis once you've seen it. You start at the piezotriquetral, at the piezoform recess, the prestyloid recess, and it just opens up like somebody's unzippered it. The treatment is, for me, is an arthroscopic assisted repair, if you will, a small incision made volarly in that area. Watch the dorsal ulnar sensory nerve, and then an out to in repair, a short arm splint. We seldom use a Munster. And you have the repair looks like this: several stitches placed across the ulnar extrinsic tear, which is seen along this area, and the immobilization. Dick Berger gave a wonderful video, which he shared with me, which, see if it'll play, which I think just puts it in your mind all that much, so that you have a torque injury to the wrist. As it torques, these fibers separate, and you get this defect between the ulnar extrinsic ligaments. It does try and heal, and so sometimes it's not quite as obvious, but this tear extends from the prestyloid recess. So once you make the diagnosis, you debride that as you do. And then you're going to simply put cross stitches across that, and that will then reef that for you. Our outcomes are fairly good. Buddy Savoy, who actually identified the lesion, called it something else, but used the same technique that you just saw, had excellent outcomes. The group that I'm associated with, Randy Culp and I, reported on 50 patients with 86% excellent results by all parameters going. Dick Berger reported on the Mayo Clinic group. They had 228 risks. Again, it's a young age group because they're usually active in sports with, again, excellent results and few complications. Type 2 is the ulnar extrinsic avulsion, and here we have a sequential disruption with the ECU, the peripheral TFC often, and the ulnar extrinsic ligaments. And this requires an open repair after you've made the arthroscopic diagnosis. In the interest of time, because we are running a little bit late, I'm not going to talk about the open repair so much, and so I'm going to stop the share relative to that if I can. What I would like to do in the last few minutes is just to show a couple of cases and run through our faculty that they haven't had a chance to really see. So let me share my screen again, and where is the cases here? Okay, and let me come back to share screen.
Can I help?
Yeah, I'm just trying to find it on my desktop. It doesn't,
Okay, okay.
it somehow keeps jumping away from me. Sorry. It's not coming up yet, is it? No.
No, we're not seeing it.
Yeah, it's hogging the whole screen.
Bailey, while you're doing that, I have a question for Will.
Sure.
Yeah, Will, you showed
That's
some
not
cases.
fair, Lee. I'm sorry, go ahead.
Sorry, and these are great. You guys are rock stars. Just in terms of the role of ligament repair in acute injuries, you showed some ligament tears. So, for example, a complete scapholunate tear or perilunate injury with arthroscopic reduction and stabilization, but not necessarily repair of the ligament. Is there a role for repair acutely?
Oh, yeah. I think, again, if it's a partial tear, a grade 2 or grade 3, we generally place a percutaneous headless screw across that. But for a complete tear, a Geissler 4, either scapholunate or lunate quetrum, I think your best repair is going to be open. So we definitely would open it up. We'd use the scope to help make the diagnosis, but for a complete tear, that'd be an open repair for me.
Are we seeing the case screen
Great,
now?
thanks.
Yes.
Yeah.
Okay, so case one is a 38-year-old right-hand dominant Cirque du Soleil performer, falls off a trapeze, ulnar wrist pain, unable to perform, clinical examination, point tenderness where my finger is. He has an ulnar snuff box compression test, positive LT allotment and chuck test, making you think about LT. If we look at his X-ray here, we see disruption in Gallula's arcs, which again are not quite 100%, but do give you that inkling on a traction view that there may be some instability. Had a bone scan done elsewhere, which was mildly positive. Had this MRI. I had an MRI arthrogram, which showed an LT leak. And here we are looking at this wrist. So we're in the 3-4. Here's our lunate scope probe is in the 6R. And here we see the TFC is solid, fully intact. And we have this LT tear. When we come in on the ulnar side, we can see in the piezo-triquetral joint, which is up by that air bubble. But here we have the tear. It's not a drive-through like the SL, but it is an absolute complete tear. And this is what you see in a complete LT tear. When we look at the mid-carpal joint, what we're going to see is wear on the proximal pole of the hamate. And that kind of wear tells you that you have a shear instability between your LT. And so, Will, what are you going to do? Is this one you got to open up and you're going to do an open reconstruction, or you're going to do your capsular shrinkage?
So I've had this exact same patient, Lee, seriously. And the problem with this is workman's comp.
Patient who came to you after you failed my work?
Well, maybe so, but this is a workman's comp, because then the question is, once you do whatever, can they go back to doing the same stuff they did? You can't answer that question. Now, for me, I would have gone straight to the scope rather than the MRI.
He came with
me,
that. They all came with it.
I got you. But to me, she was a little bit ulnar positive. And with that, with the LT ulnar positive, I would have done ulnar shorting. Now, I think I saw you shrink, but for me, I would have done ulnar shorting for that.
And I think that's reasonable. And here I did a shrink. And as you pointed out, shrinkage has not been good in other joints, but in the wrist, we can immobilize them. I don't think that the interosseous ligaments themselves shrink very well because they're often membranous, but you need to shrink both the volar and dorsal capsules and the mid-carpal joint. We also debrided that arthroscopic lesion, whether that helps. We then reduced it, and you have to reduce it from the mid-carpal joint, pinned with buried pins for 8 weeks. Went back to work for Cirque du Soleil, reasonable grip and reasonable range of motion. And that was a number of years ago. In fact, when we went to the academy in Vegas, he looked me up. Okay, case 2. And I think this may be our last case, but I think it's an important one. 27-year-old professional golfer, acute ulnar wrist pain after a mishit, unable to play effectively. Has symptoms for about 11 months, only activity related, and it doesn't bother him all the time, but it bothers him when he drives a tee shot or when he hits wedge shots. When you examine him, he's point tender over a little more distal than the normal LT. His grip strength is weak, only an ulnar deviation. He's got this X-ray with a lunate facet you can see is about 3 millimeters. An MRI was done, multiple stops, and without going into it, you can see that there is some cystic change around that proximal pole. He's had a number of studies done. He gets better with a cortisone shot. And here is his thing. His radiocarpal was perfectly normal. The LT ligament was intact, but he has this bare area of cartilage opposite his type 2 lunate. Anybody on the panel? Rob, Tom, Will, what are you going to do at this point?
Well, this is Tom. I'll pipe up, I suppose. It's very clear he has degenerative change at his type 2 lunate or type 2 lunate on the proximal hamate, and I think there are options to address that directly. I've actually tried drilling that to try and replicate what's done in the knee, and that's been unsuccessful. And I think in this you could consider arthroscopic resection of the proximal portion of the hamate. One thing though, when I see this, one thing I'm sure I rule out is a hamate hook fracture, because sometimes you can have edema throughout the hamate. And actually it's from the hamate hook, but obviously you have a arthroscopic finding here.
Yeah, no, that's a good point that when you see that kind of edema, it isn't always impaction, and you have to make sure the LT was there. But this is a relatively simple procedure to do. You just take a burr and take it down about 3 millimeters so it no longer contacts with the lunate facet. He became asymptomatic. He was playing and teaching 6 days a week, but he missed the PGA cut for whatever that's worth. But I think it is important to remember when you're analyzing x-rays, the difference between the common type 2 and the type 1 lunate. Type 2 is more important. It stabilizes the wrist in terms of lunate instability, but it is a high area of impaction with load. Andy Palmer and his crew showed the halt lesion, as called, which is where you had hamate arthrosis, as we just saw, secondary to a lanatotoquetral tear. In this case, it's isolated hamate impaction, and it's not as common as LT injuries with halt lesions, as you see here, but it is a real thing, and it can be very helpful. I'm not going to take you through the whole series, but you can get an excellent result with this. And we've approached our 8:30 bewitching hour, so I think I will stop at this point, and stop sharing and go back to the final things, just to emphasize that this was the 9th of 10 sessions, and we'll see if the other rest shares, but this is the 9th of, wants to put me back in that. The 9th of 10 sessions. The next session, which is a kind of summary of all of the seminars which have gone before and shouldn't be missed. All your questions will be answered in that. It still wants to go back to this, but all your questions will be answered in that. And you also, this is all available. It's being taped on the AO website. So I thank all of the attendees for their attention. I'm sorry for some of the technical things. We tried to work it out in our practice session, and it obviously ran smoothly then.
No worries, Lee. Lee,
Thank you all.
Thank you, Lee. Thank you, Will. Thank you, Tom. Thank you, Rob. Outstanding session. I learned so much from you over the years, and thank you for continuing to educate us. I did really appreciate it. Wonderful job and great session. Thank you. I'll quote Chuck again and say, "You're rock stars." I will say, just if I could have the attendees' attention briefly, Chai had asked us to, I'm going to share my screen real quick and talk about our next educational offering from AO North America Hand is this Hand Therapy Essentials, which will be starting on April 29th. Basically, a surgeon and therapist partner together with an expert panel and discuss some of the different pathologies that we run into. Chai Mudgal and Becky Naduski are co-chairs for the course, and I just wanted to put a plug in for everyone to be aware that more educational offerings are coming as we wind down the RIS Summit. And to echo Lee's comments, next week we will be doing our wrap-up session, and we look forward to seeing all of our faculty and hopefully all the participants. And I wish you all a great evening. Have a wonderful evening, and we'll nice weekend, and we'll look forward to seeing you next Thursday. Thanks, Lee, for giving me a chance.
Fantastic job, everyone. Just a reminder, for those of you who wish to get CME credit, this will be available after the next session. After the conclusion of the next session, you'll be eligible to receive credits for all of the sessions. That's the 13.5 hours, I believe. And so stay tuned and log on next week. Thanks again, Lee and team. Awesome job.